S.P. Ray-Chaudhuri Memorial Foundation lecture with homage to our founder of this university, Mahamana Pandit Madan Mohan Malviyaji. I would like to request Professor Raman, President of SPRC Foundation, and Dr. Gaurav Pandey, Treasurer of SPRC Foundation, to please accompany our chief guest, Professor Punjab Singh, Chancellor of Rani Lakshmi Bai Central Agricultural University, and Dr. Soumya Swaminathan, Chairperson of MS Swaminathan Research Foundation, on the dais. I would now request Ms. Vanshika and Ms. Neha to please present floral bouquets to our chief guest, Professor Punjab Singh. Jaldi karo. Jaldi karo. Aage se. And Neha to Dr. Soumya Swaminathan, please. Aage se chale jaओ. All events in the university, we start by the recitation of Kulgeet for Madam Yu, and all present in the audience who are not directly associated with BHU. I would like to tell that this Kulgeet describes the aura and essence of Banaras Hindu University and the region where it is located, that's Kashi. But more important than that, these words, this Kulgeet was written by famous scientist, Professor Shanti Swarup Bhatnagar, who was a faculty in the Department of Chemistry at Banaras Hindu University, and on whose name the highest award in science has been instituted. And this was composed by Pandit Onkar Nath Thakur. So I request you all not to please clap after the Kulgeet. So for Kulgeet, I invite Saurabh Sagar, Olivia, Tanvi, Amrita, Debashruti, and Papri.
मनोहर अतीव सुंदर ये सर्व वेद्या की राजधानी राजधानी मधुर मनोहर अतीव सुंदर ये सर्व वेद्या की राजधानी राजधानी ये तीनों लोकों से न्यारी काशी सुज्ञान धर्म और सत्य राशि बसी है गंगा के रम्य तट पर ये सर्व वेद्या की राजधानी राजधानी नए नहीं है ये ईंट पत्थर है विश्वकर्मा का कार्य सुंदर रचे है विद्या के भव्य मंदिर ये सर्वश्रेष्ठी की राजधानी राजधानी यहाँ की है ये पवित्र शिक्षा कि सत्य पहले फिर आत्मरक्षा बिके हरिश्चंद्र थे यहीं पर ये सत्य शिक्षा की राजधानी राजधानी वेद ईश्वर की सत्यवाणी बने जिन्हें पढ़ के ब्रह्म ज्ञानी थे व्यास जी ने रचे यहीं पर ये ब्रह्म वेद्या की राजधानी राजधानी व मुक्ति पद को दिला आने वाले, सुधर्म पथ पर चलाने वाले, यही फले फूले बुद्ध शंकर, ये राज ऋषियों की राजधानी, राजधानी। सुरम्य धाराएं वरुणासी, नहाए जिनमें कबीर तुलसी, भला हो कविता का क्यों ना आकर, ये वाग वेद्या की राजधानी, राजधानी। विविध कला अर्थशास्त्र गायन, गणित खनिज औषधि रसायन, प्रतीचि प्राची का मेल सुंदर, ये विश्वविद्या की राजधानी, राजधानी। ये मालवीय जी की देशभक्ति, ये उनका साहस, ये उनकी शक्ति, ये मालवीय जी की देशभक्ति, ये उनका साहस, ये उनकी शक्ति, प्रकट हुई है नवीन होकर, ये कर्मवीरों की राजधानी, राजधानी। मधुर मनोहर अतीव सुंदर, ये सर्व विद्या की राजधानी, राजधानी। मधुर मनोहर अतीव सुंदर, ये सर्व विद्या की राजधानी, राजधानी।
Now I request Professor Rajiv Raman, President of SPRC Foundation, to please welcome the guests.
Professor Punjab Singh, the chief guest, ex-vice. Speaker, Dr. Gaurav Pandey, the treasurer, distinguished friends, students, colleagues, ladies and gentlemen. I consider it a singular pleasure and privilege to extend to you all a very hearty welcome to this 24th Professor S.P. Ray-Chaudhuri Memorial Foundation Lecture. I extend a very hearty welcome particularly to Dr. Swaminathan for having accepted our invitation. Those of us who are in the process of inviting and fixing a date for her lecture know how extremely busy she is. And it shows also that right now when she comes here, she was actually yesterday in Bombay. Today she's giving a lecture here. Immediately after the lecture, she leaves and goes to Lucknow, where again she has a meeting in CDRI. Despite all this very busy schedule, she has been able to give us time. It's indeed a pleasure for us to welcome you and to thank you, madam, for coming. There's also a small more reason for me to be particularly grateful and happy that she is here, because her illustrious father, Bharat Ratna M.S. Swaminathan, was, of course, a very great agriculture scientist, but he was also a very great friend of Professor Ray-Chaudhuri. And about 10 or 15 years ago, we had also invited him to come to deliver the lecture, to which he had very kindly agreed. But busy as these people are, and they ought to be busy, however much he tried, he couldn't make it. And so I am doubly grateful to you for having made it possible. So you make up for him too. Our very great welcome also to Professor Punjab Singh. Those of you who are slightly grayish in hair know that he was our Vice Chancellor here a little, maybe 20 years ago. And he was one of those Vice Chancellors who told us that doing science in your lab is extremely good, but better it would be when this comes out of your lab and goes to the public at large. Lecture after lecture, addresses after addresses, he insisted upon us that we should do it. And actually, some of the buildings that you see here, for instance, the Center for Genetic Disorders, is a testimony to his encouragement and persistence with us to tell us that you have to excel, you have to be in the public. It's very great fortune that he was here, and I should tell you that on 13th March, he had a meeting somewhere else. We are very grateful to you, sir, for having postponed that meeting to be with us here today. And that shows your love for us, for BHU, and also, most importantly, for the speaker whom he knows for a very, very long time. We are, of course, grateful to you all, audience here, for having made it to the lecture. Made it to the lecture for a man in whose memory it is established, Professor S.P. Ray-Chaudhuri, who was head of the Department of Zoology of Banaras University from 1960 to 1971. But that's a very small reason for us to have a foundation in honor of him. He was much, much more than that. Professor Ray-Chaudhuri, he came back from England, having learned genetics with H.J. Muller, who was just the second geneticist to get Nobel Prize. And he started genetics research and training, at least animal genetics research and training in India in a proper way. Of course, he was aided by another great scientist, J.B.S. Haldane, who helped him in set up a laboratory in Calcutta. When he came to Banaras, at that time, the zoology still was a formaldehyde, picric acid, post-mortem observational science in India particularly. It was his grit and effort that made this science vibrant, living, and a knowledge of living world. When we started dissecting not only scoliodon fixed in formaldehyde, but we also began to grow flies in generation to generation. So that post-mortem zoology to a living world of animal science is what he did. Not only for zoology, I tell you, my ladies and friends and gentlemen, but he went all around the country and made zoology what it is today. Not alone, of course, there were friends and people who helped him, but he spent his life doing that. And therefore, after he passed away, his students, friends, colleagues, his family, we all thought the best tribute to him would be that we have a foundation and make it an effort to take science to the public at large. That's what, as I said, Professor Punjab Singh was telling us. That's what you would remember Professor Swaminathan would tell us. That's what we are all supposed to be, particularly when we are teachers and when there are students. But students here have to know that what science you learn is only a small part. What you have to learn is to think science, think scientifically. And if we can do that, we have done a good job. And once we do that, it's our duty, as is yours, that we go to the public at large and tell them that the way to live is to think scientifically. And if we are able to do that, I think we have paid a tribute to him and to the total scientific community of this country. I welcome you again. Thank you very much.
Thank you, Professor Raman. As we know, this is Professor S.P. Ray-Chaudhuri Memorial Foundation lecture. And as Raman sir was telling, the ecosystem that he built is still running today, and we're trying to keep it up. And we are having the 24th Memorial Foundation lecture bears a testimony to that. So now it's time to introduce our speaker, Professor Dr. Soumya Swaminathan. Now, I'm honored and privileged to be introducing Dr. Soumya Swaminathan to this audience. And at the same time, I find this very challenging. Challenging because how to introduce a person, a personality whose name speaks volumes. So Dr. Soumya Swaminathan is presently chairperson of MS Swaminathan Research Foundation. Before that, she was chief scientist at World Health Organization, which is a very prestigious position. She was the global voice of the WHO. And during the time of pandemic, the briefings that she used to deliver to the press twice every week was what the world actually waited for, to understand or to know what are the latest developments for beating the pandemic at the best. And prior to that, she was Deputy Director General of World Health Organization. So these two positions, she was the first Indian to be there, and all Indians are very proud of that. She's again in She's again into international forum. She's presently co-chairperson of global commission called as Our Common Air, which is striving to improve air quality and ultimately to improve human health. She was the Director General of Indian Council of Medical Research, and being at that position gave a great impetus to the medical community, mostly because she could understand the public systems and the public health management. And being a researcher, she was able to mm, bridge the gap between the research and its translation. She is trained as a pediatrician from India, the UK, and the US, and specializes in neonatology and pediatric pulmonology. Her research interest also lies in the field of tuberculosis and HIV, and she was the director of National Institute of Health and Tuberculosis. And she has published many papers in very, very high impact factor journals. She has published many chapters of books and authored many books. She has received several awards and honors. And the last award that she received till today was yesterday. She received the YB Chavan National Award at Mumbai. She is a fellow of US National Academy of Medicine and Academy of Medical Science of the UK. She is also a member fellow of all the three academies of India. And before I invite her for the talk, I would just like to give the audience a small peep into her childhood days. Being grown up or being born in a house of a very great scientist, Professor M.S. Swaminathan, academics was in the air. And there were many scholars and Nobel laureates who visited their place. And she was a witness to the discussions and deliberations they used to have. And not only that, she used to visit her father to the field trips. And there she could understand who are the end users of the products. And it helped her in better delivery of how to convert from lab to field. Her mother was a very great philanthropist, and she was associated with an organization called as, which built mobile creches for migrant laborers, which we all know and is a very great job, because if a mother is working and if she knows that the child is being taken care very well, she'll be at peace because she has to strike a balance between the family and the work. And all these experiences from the house and the field, being with less privileged people, transformed her into the humane that she today is. With these words, I request Madam to please come.
Namaskar and good afternoon, everyone. First of all, let me thank Professor Rajiv Raman and the other members of the SP Ray-Chaudhuri Foundation for having thought of me as one of the people who should give the memorial lecture. I've seen the previous list of speakers and they're all very eminent scientists and experts who have delivered. So I'm honored to be delivering the 24th lecture in the memory of a very great scientist who had a very, very close and long association with this university and built a whole generation of scientists, as Professor Raman was telling us. It's also wonderful to be back at BHU. I've been here many years ago when I was DG ICMR, but my only regret is that this trip is also very short. I'm not able to stay long enough to visit more of the departments. I had today, of course, a very packed day, and I tried to meet as many people as possible and visit the labs, but there's a lot more that to be seen, obviously. Thank you, Madhu, for that very nice introduction and the research that you did. And of course, it's wonderful to see Professor Punjab Singh and a lot of other friends and colleagues. We also heard a very beautiful song at the beginning, which was written by Professor Dr. Bhatnagar himself and set to beautiful rag. And it was, and the words were so meaningful, and I'm sure that every person associated with BHU loves that song. So thank you for for singing that very beautifully. So as Dr. Madhu was saying, I spent 5 years at the WHO. Nahi ja rahi. Let's see if that is better. Mera gala bhi thoda sa kharab hai, so I hope you can hear me now. Is it okay? It's on? Okay, I think now it's fine. So of my 5 years at WHO, actually, almost 4 of those years were during the pandemic. And it was quite, I suppose, like a foresight that the Director General had, that he created a position of Chief Scientist in 2019. And even though WHO, which was, one of the UN agencies that was formed after the Second World War, it's the only international health agency, and it's a normative agency. So UN agencies are of many kinds. A normative agency is one that sets the guidelines and standards, and that people, around the world depend on WHO for the health standards and recommendations. So despite the fact that all its work is based on science, based on data, right from the very beginning, the fact is that there was no explicit science division. Put that off. Put it off. Off ho gaya? Okay, let's try again now. I think this is better. अभी भी आवाज आ रही है. Okay, so now I don't know if it's audible. Is it audible? ये बंद हो गया क्या? No? नहीं, 2 करने से वो आवाज आ रही है इसमें. नहीं. अच्छा, ठीक है. टच नहीं करना. Hello, can you hear me now? I think it's okay now. Yes, all right, good. Sorted that. Yes, so I think what I wanted to do today is share some of my experiences that I had, of course, at the WHO, but also based on my experience in research in India. And I should tell you that medical research was not an easy field to get into when I was young, like many of you, and I had finished my training, my MD. I wanted to be a researcher right from very young age. Maybe it is because I grew up in a research institute. And so from my early childhood, I saw PhD students in our house all the time. So I wanted to be a researcher. But then I ended up doing MBBS and then an MD, which was not actually my dream to be a doctor. I just wanted to be a pure science researcher in genetics, actually. But and then I thought I would do human genetics. But then I got very interested in pediatrics in children. I wanted to specialize. So I did my MD. And all along, I felt that there was something missing in my training, that I did not have a good grounding in research, even though I got very excellent clinical training. And so this is why I went abroad to do a fellowship. And after 3 years doing fellowship abroad, I felt much more confident of being able to, you know, be a principal investigator. But when I came back to India, the advice that all the seniors gave me is that you cannot have this type of a career in India. It doesn't exist, where you can do some teaching, you can do some clinical work, you can do also your own research depending on your interest. And that is what faculty abroad do. They do have protected time for research. They have also their clinical, and I didn't want to give up any one of those, because if you give up your clinical work, then I felt that whatever I do would be like in an ivory tower without having that connection. So it was actually very difficult to find a position, because medical colleges, again, very few where, you know, there's any kind of interest of research. Just you can count, you know, on a handful of medical schools that do high quality research, and most of your time is taken up by teaching and clinical care. So I think that that's still a gap in India that, you know, we're trying to bridge. And it's very nice here to see that the Faculty of Medical Sciences is collaborating with some of the basic science work that's going on, both, you know, in the Department of Zoology and also in the Department of Environmental Science, where I went today, the Institute of Environmental Science and the Climate Change Group, that there are these interdisciplinary collaborations. And I think that really is the future. There's no longer science, I think, which is can be done in a silo. And if you look at any of the major discoveries that are made, it's all happening with interdisciplinary collaborations. So the title is Lessons from the Pandemic for Science and Public Health. And if we just step back a little bit, we remember those days in December of 2019, when there were some reports in the newspapers that there's some strange pneumonia happening, you know, in Wuhan. And there were, in fact, there was a doctor there, a young doctor, an ophthalmologist, who had posted on Chinese social media his concern that there was very unusual cases in the hospital and that needed further investigation. Unfortunately, he himself died of COVID a few weeks later. He was only 31 or 32 years old. But it took some time there for the authorities to really acknowledge that there was a serious problem. But on the science side, of course, they are very advanced. And so very quickly they were able to sequence the novel virus. And by the 10th of January 2020, we knew that it was a novel coronavirus. And as you know, we've had two previous human coronavirus outbreaks, the SARS outbreak in 2003-04, and then the MERS outbreaks, which continue to occur. That's the Middle East Respiratory Syndrome, which is also a coronavirus, a beta coronavirus. So this was a different one. It had some similarities with SARS-1, and that's why it was given the name of SARS-CoV-2. And there is a methodology for all of these, how you name viruses, how you name diseases. And in fact, in the beginning, a lot of people were calling this all kinds of names, if you remember. And even Mr. Trump was, calling it Kung Flu and things like that. And the whole idea of the WHO nomenclature naming system is to avoid stigmatization of a place or a person. And so normally in the past, it may have been called Wuhan fever or Wuhan pneumonia or something. But the idea is that you name a disease based on certain criteria. And so it was called COVID-19 and the virus was called SARS-CoV-2. Now, at the end of January, the WHO actually declared it as a public health emergency of international concern. This is the 7th time that such a thing has been declared. In the past, it's been declared for polio, for Ebola, for Zika, and for influenza a couple of times. But this was the first time it was done for a coronavirus. And the fact is that at that time, there was very little information about the spread, how extensive it's going to be. And at January 30th, there had been about 82 cases reported outside of China. And I think at that point, there were no deaths. Only the deaths had been in China alone. But of course, then we saw that it spread very, very rapidly, and no country in the world was really prepared for something like this. And we saw the number of cases and the deaths mounting very rapidly. Now, the WHO continues to track the epidemiology of COVID, even though many countries have now really reduced the amount of testing that they do. And so the numbers don't really mean that much, because as you know, today when you have a cough and cold, you don't go and test for COVID. Most people don't, some still do. Whereas a couple of years ago, you would be sent off to have a test, etc. So you have to keep in mind. So when you see that graph over there on the right-hand side, basically starting from the beginning of 2020 till January 21st, 2024, you see the major spikes there are really the alpha variant towards the end of 2020, then the Delta wave in 2021, where India was also very badly affected, and then the very high peak is the Omicron variant, which was the most infectious variant, which came towards the end of 21, beginning of 22, and then we continue to see the Omicron variant being the dominant variant. Now, you can see that the different colors there also represent different countries, but more or less many countries followed the same pattern. And on this side, basically, it is the number of COVID deaths that are being reported to the WHO. And again, you can see that there was a very rapid increase in the number of deaths being reported in 20 and 21. And after that, it has more or less plateaued. It doesn't mean that there are no deaths now, but just that the numbers are relatively less. Now, of course, one of the things that happened was the massive economic impact globally. And in fact, if you look at the whole of the 20th century, this COVID-19 actually had much bigger impact on the world economy than any of the previous events, including the global financial crisis, World War II, World War I, and so on. And on the other side, you see what happened in different types of countries. So if you look at the red dots, those are representing the low-income countries, and the dark blues representing the high-income countries. And if you look at total spending, the first graph, that is the government spending, it was the lowest in the low-income countries. If you look at the third line, which is selling of assets, again, it was low-income people and low-income countries who sold their assets. And if you look at who received more government assistance, again, the high-income countries were the ones where the government was actually pouring money, not just to individuals, but also to businesses. So massive social security net was being rolled out. So definitely people living in low-income countries suffered the most. We also saw an impact on nutrition and on many other diseases. And it was estimated that, additional 150 million people or so were pushed into poverty. We also saw at the bottom, you can't read, but basically what the rings at the bottom are showing are the SDG targets for the global nutrition targets. On this side, we have the maternal, infant, and child nutrition targets. And on the other side, we have the global non-communicable disease targets, things like salt intake, reduction in obesity, and high blood pressure and diabetes. And on the nutrition targets, we have things like childhood stunting, also breastfeeding, low birth weight, anemia. And what it shows is the orange rings are the countries which are off course. They're not on track for the SDG targets. So you can see in both sets of indicators around nutrition that the world is not on track. And what COVID did is it showed us the link between non-communicable diseases and infection. So people who had already hypertension, diabetes, etc., were those who got more sick. Now, COVID also impacted disruptions across health services, and I'm sure that everybody here experienced that. So if you needed a regular health checkup for some other disease, like if you had cancer, if you have TB, if you have mental health illness, you have something else, then it was all disrupted. And again, this happened across countries because the WHO was actually doing what we call the pulse surveys to see whether essential health services were continuing. And we found that, of course, in 2020, there were massive disruptions. But even at the end of 2022, you can see that at least about 25 to 30% of countries still had service disruptions in sexual and reproductive health services, maternal newborn health, child adolescent health, just shown as an example here. And in 2020, we found about 75 to 80% of countries with disruptions. And again, the low income countries did worse because obviously they had weaker health systems, they had less staff, less facilities, and everything was diverted to COVID. So the lesson here is, of course, that you have to build a resilient health system. You need to be able to, in a time of an emergency, continue with the regular services and be able to deal with an emergency. And that requires a great deal of planning and also investment in human resources as well as in infrastructure. We had also, of course, seen, that there were shortages of many things. In the beginning of 2020, there was no PPE in many countries, and the countries that were manufacturing PPE were keeping it. They were not allowing it to be exported. So even simple things like masks and gloves were not available. And we all saw, health workers, even in the UK, covering themselves with garbage bags and things like that. So the supply chains were impacted. There was a huge burden on healthcare workers, and that a lot of them actually lost their lives, doctors and nurses and other healthcare providers taking care of patients, but they themselves succumbed to the infection because of the heavy load of infection they were facing in the health facilities. And as I mentioned, there was disruption of the essential health services. So a few things that came out of this. One was that countries realized that if you're completely dependent on importing things, then you're very vulnerable. And so we saw in India also that in the beginning, we were import dependent for a number of things, including reagents for doing the lab tests. We were not able to scale up our PCR. We had one lab, NIV, in Pune, and all the samples were going there. Very quickly, ICMR and others worked hard to expand the number of labs that could do PCR. Luckily, we have a lot of existing competency in whether it's in private sector, public sector, in academia. So they were all used actually for this type of testing. And then, of course, very quickly the Indian industry was able to start manufacturing many of these things, and everything became indigenously manufactured. But this was not true of many other countries, like Africa, for example, does not manufacture hardly anything that they need. And so those countries really suffered. And again, it points to the fact that we don't have a global trade system which is very equitable or which is designed to deal with something like a pandemic. Because ideally, you should have a global system of governance which can actually deal with these things in a way that's more equitable. Now, I'll say a little bit about vaccines, because obviously that was a very focus of the work that we did. And the goal in the beginning, you see, when we knew it was a coronavirus, it wasn't clear that there would be a vaccine. I mean, there had been no vaccine developed for any coronavirus in the past. But there were groups around the world who were trying to develop vaccines for MERS. And there were some groups who had tried for SARS-1, but then SARS-1 went off. And so those programs actually had quietened down, or they had not been continued. There was something sitting in somebody's fridge somewhere. But the Oxford group had been working on a MERS vaccine using this chimpanzee adenovirus platform. Similarly, there were groups that had been working on mRNA. And as you know, last year, the Nobel Prize went to Katalin Kariko and Drew Weissman for developing mRNA vaccine. Well, they started their work in the late 80s. And if you must read or listen to Katalin Kariko's interviews. She's an amazing woman. She's from Hungary, and she migrated to the US for her studies and then got a job at the University of Pittsburgh But then she lost her job because, she could not get the research grants. Nobody was interested in mRNA at that time because it was very new and nobody thought it's possible. Because as you know, if you take mRNA and inject it, it's immediately destroyed. It is not a stable molecule. And so what they did was to make changes in the structure uh, with adding some uracil, etc., which actually gave it that stability. And the other thing was, how do you get it into the body? And that is where the lipid coating came in. So the lipid nanoparticle work was being done by other people, but then when they worked together, they found that you could actually create a stable mRNA with a lipid nanoparticle coating that can be injected. Now, this work from the 1990s for almost 35, 40 years had not resulted in any practical application. You see, but these two people kept on and on working at it and solving one problem after another. And it was during the pandemic that Moderna, which is a small biotech company at that time, had been working on the mRNA platform for chikungunya and for Zika and a couple of other infections. They took the sequence of the spike protein, and the NIH scientists had already worked out that the spike protein of coronavirus is likely to be the most immunogenic. So you see, there are very different pieces of scientific work that had been happening in different parts of the world that came together at that time. And so January 10th, the coronavirus sequence was released, and within a week or so, they actually had a construct of the vaccine using the spike protein. And in a few weeks later, they were able to go and inject it into animals because, of course, the mRNA platform is very quick, easy to manufacture. It's a chemical process, not a biological process. So the point is that if the investment in that research and science had not happened over the last 30, 40 years, mainly using taxpayer money, NIH grants, etc., then we would not have had these mRNA vaccines during the pandemic. The other thing which happened, which was very dramatic, was if you look at the timeline of development of vaccines, on an average, it takes 10 to 15 years to go from preclinical to phase one. Phase one is done in healthy humans to basically look for safety. Then you move into phase two, which is a dose finding study. Usually you look at immunogenicity. And then you go into a phase three, which is a large efficacy trial where you actually look for protection against the disease you're interested in. Then once you do that, the company then starts thinking about manufacturing and scaling up manufacturing, then go for regulatory approval, and then finally distribution. So you can see the shortest time it has taken for a vaccine to come to market so far has been the mumps vaccine, where Dr. Hillman, who's a very famous vaccinologist, he developed, his daughter had mumps, and then he took the virus and he made a vaccine. So 4 years was the record before that. But you can see what happened during COVID, this accelerated timeline where everything was overlapping. It was not sequential, it was parallel. So even when the preclinical was going on, the phase one had already started. And then the phase two was overlapping on the phase one. The phase two flowed into phase three. There were no breaks in between. And at the same time as that was happening, companies were already getting their manufacturing infrastructure in place. And all this was done at risk, knowing that the vaccine may or may not be effective. But there was no time to waste. So, of course, billions of dollars were spent on these preparations. And again, governments put in a lot of that money, but companies also did a little bit. And the WHO's role here was very important because at the beginning of 2020, of course, as I was saying, nobody knew that there would be a good vaccine or not. We know for influenza, for example, that the vaccine efficacy is not more than 40 to 60%, despite so many years of influenza vaccine development. And so we didn't know for COVID, this new virus, how good it will be. And so we had this, the way WHO works is through expert groups, and they actually set the benchmark saying, a minimum of 50% of efficacy would be good enough, again, based on influenza experience, and of course, safety parameters were outlined. So that was done in March, April of 2020, and all the regulatory agencies like FDA and the European Medicines Agency and the Indian regulators, Japanese regulators, all of them agreed to this, so that there was a international accepted benchmark. Now, of course, we talked about mRNA and how it works, basically by injecting nucleic acid. Um, and actually, at one point, there were over 300 vaccines in development across a range of platforms. You had mRNA, you had DNA that was actually in India being developed by Cadila. You had inactivated vaccines like Covaxin. You had the adenovirus platforms like the Covishield. You had subunit protein vaccine like the Novavax. So many of these were new. The platforms were new. Of course, they all use the spike protein. And the historical experience is that only about 7% of vaccines that start preclinical development eventually succeed. And once you reach a clinical trial, about 20% has a chance of succeeding. And at that time, we didn't know which vaccine we could be given to children versus older people. And we also knew we'd need a very large volume, so more vaccine, the better, etc. And WHO also developed a prioritization roadmap where we said whatever volume is available, we have to distribute it equally around the world, and the elderly should get it first because they are at risk of death. Healthcare workers should get it, then others, frontline workers. So that was actually the goal for equitable vaccine distribution, and that is why we also worked on COVAX, which was really an unprecedented effort to ensure that all countries had the benefit of whether it was drugs or vaccines. And WHO, Gavi, CEPI worked together on this. And the idea was, let's have 2 billion doses of vaccine by the end of 21. And a large number of countries signed up. Of course, the lower income countries would be getting it free, and the other countries actually were supposed to pay for the vaccine. But eventually, what happened was very different. And at the end of 2021, we found that, no, this is the middle of 2022, while almost 70% of the world had received at least a dose COVID-19 vaccine. If you look at only low-income countries, and again, you can see most of them are concentrated in the African subcontinent. A few small ones, in Southeast Asia, etc. But only 20% of people in these countries had received one dose. And this was a number of reasons. One is they got the vaccines very late, and the African population by then was fed up. And they had also had the experience of COVID with not very high mortality. And so there was no real incentive for them to want to take the vaccine. And also their health systems are not very good. So they were not able to launch the kind of vaccination program that we saw in India that was done, so successfully. So I think the lessons from, and in India, of course, thanks to the private sector, we have excellent vaccine manufacturers, and the government support for them. They were able to really step up and manufacture. The Serum Institute manufactured, 2 billion doses, just that one company. And then we had Covaxin as well. So we did not have a problem, but what actually happened was that countries that could not manufacture, they had a very big problem. So the R&D blueprint is something that was set up at the end of 2015 as a response to the Ebola outbreak in West Africa, whereas you remember a lot of people died, 11,000 people actually died of Ebola at that time, and WHO was criticized for not really responding effectively. And also the research which took place at that time was very uncoordinated. And many groups were coming in and trying to do their own research, and nothing came out of it. So many people died, but at the end of it, the opportunity for research had been wasted. So when we were thinking about this, and you see this report that we came out with in March 2020 after we had a big global convening of experts to develop a research roadmap. And the idea was that for this pandemic, let us accelerate research, both to care for those affected and to prevent spread of the virus, as well as planning for future epidemics and pandemics, that how do you build the platforms that can serve us in the future. So in that 2-day meeting that we had in February, we were able to identify a number of knowledge gaps across different thematic areas. At that time, of course, we didn't know much about this virus. So, what's the human animal interface? Where did the virus originate? By the way, that's a question that we still have not answered. That research is stuck because the lack of cooperation from China. But on clinical, we learned a lot in the first few weeks. Then vaccine development, behavioral and social science, transmission, therapeutics, and very importantly, ethical considerations. So I'll say a little bit about that. So this was done, and this document was produced so that people around the world could use this document, and whatever, depending on their expertise, they could say, okay, I'm going to address this question. And we had developed expert groups around each of these thematic areas, and these groups were constantly meeting every week. Every 2 weeks they would meet, they would exchange, they would share the data and information, they would publish. So one of the things, of course, which we saw was important was the was the variants. Just turn this on. We know that viruses mutate, and so it was expected that it's fine, variants would emerge. But the thing is that there's no way of predicting whether a particular mutation is going to lead to a change which is better for the virus or worse for the virus, or better for the host or worse for the host. And so this is why you need the studies on genomics to be done hand in hand with the clinical and epidemiological studies. Of course, what happened was that a huge amount of genomic sequencing was done, unprecedented, and millions of sequences. And not only were they done, the data was shared on a platform called GISAID, and that enabled everybody around the world to constantly be looking at the sequences, analyzing. And so we had a group of experts that was looking at virus evolution, and they were the ones who would determine whether a particular variant was to be called a variant of concern or not. And again, that depended on either from after some time, you could tell from some mutations what that function is of that mutation. That came with experience. But even then, you needed the animal and the human data to be able to say, and then we, of course, saw the variants. The next variant would come and completely wipe out the previous variant, because each new variant was more transmissible. And some of them were more severe. The others, like Omicron, were less severe. So again, we were focusing on the science to drive the understanding of this virus and how it behaves, looking at natural history. And natural history is still important today because we have, as you know, this condition called post-COVID or long COVID syndrome, where people suffer from a variety of symptoms like fatigue, palpitations, what they call brain fog. A lot of people say, I'm not able to work like I used to be able to, can't concentrate, breathlessness. Number of different organ systems were impacted by COVID. It was not only a respiratory virus. And so it's really important to have these long-term studies that looked at all of these factors, including mortality. And we saw very early on the risk factor was age, older age, underlying health problems, etc. Transmission was quite, I must say, an area where there was a lot of debate, even some controversy. In the beginning, it was believed that it was a droplet transmission like influenza. And that is why, if you remember, there was a lot of focus on hand washing and on keeping distance from people, because it was believed that if you kept 6 feet of distance, you would not get infected because the droplets actually fall to the ground. Now, this is where the aerosol engineers came into the scene, and there was a huge amount of work done by engineers working with doctors, and they developed models, and they showed that when you cough or when you breathe out, you have all of these different particles of varying sizes, and it's basically explained by physics how those particles behave. The larger ones, of course, fall down and they fall to the ground or to the surface, but the smaller ones remain suspended in the air for a long period of time, and it depends on the ventilation of the room and how many people are in the room and for how long you're exposed. So the chances of you're getting an infection depend on all of these factors. You have somebody who's very infectious and who's coughing, and you're sitting in that room, so that's why you had case reports of people getting infected in restaurants, as well as in an office space which is closed where you spend 8 hours or 10 hours with somebody who's infected. The other thing which was different about this SARS was that even asymptomatic people could spread the infection, whereas the previous SARS, it was only people who were quite sick already and who were coughing. So it was easy to identify that person, isolate them, quarantine the contacts, and that's how SARS-1 was actually controlled. In this case, even if you did all of that, lots of asymptomatic people walking around infecting others. And this is why we could not really contain this. So a lot of work was done on the settings in which transmission can be amplified. Then very interesting work was done on sero-epidemiology, that is on periodic sero surveys, and India did a fantastic job. ICMR did these 4 sero surveys about 4 to 6 months apart. The first one was in June-July 2020, and then going on to the end of 21, and you could see the proportion of the population that got infected, and that kept increasing, till the point where almost 80-90% of the population had antibodies after Omicron, because Omicron just spread like wildfire. And the fact is, they found no difference between states. All states had the same amount of antibodies people had. What was different was the number of cases that were detected and reported. So the testing capacity varied between states, just like it varied between countries. And so from the African continent, for example, we used to get very few reports. It's not that they didn't have COVID, they didn't have the testing. And so if you did the sero surveys, even Africa, same pattern, 60%, 80% infected, but number of cases reported to WHO, very few. So in India, we saw the same pattern between states as well. And so that is why you need all these different ways of assessing what is going on, and the data. The data is extremely important, that it should be generated in time, and it has to be shared, it has to be analyzed properly, and then what are the learnings from that, and how does it impact policy. So I think it was a very good example of epidemiology. There were a lot of modeling, a lot of modelers were there. In fact, everybody turned into a modeler for some reason. And so there were hundreds of models being projected that this is going to happen, that is going to happen. Most of them turned out to be, not accurate, because modeling really has to be based on very good data. And if your assumptions are not correct, your model is going to be off. So in India, what happened is, I think there was a group of modelers who said at the end of 2020 that India is fine. We've done very well, which we had in 2020, and that we have no more risk, and that we're done, and that we all have BCG. So there was another group who said BCG is protecting us. So there wasn't any evidence to any of this, but it helped people to become more relaxed and drop some of the safeguards. And then in 2021, we saw a big wave, the Delta wave, which was actually the one that resulted in the maximum number of deaths. So the lesson again is that when you are faced with something new, you don't come to conclusions without having all the facts, and you have to continue to be vigilant, you have to continue to study, and you have to listen to the scientists. So again, just an example of the kind of issues that come up. Regulatory. Okay, we don't often think about regulatory because unless you're working in that field, how do you authorize and license vaccines, particularly second generation vaccine? That means first generation vaccines, they went through the efficacy trials and then the people start getting vaccinated. So now you have a population that is already vaccinated partially and that's also been infected. You have antibodies. Now new vaccines are developed. How are you going to test them? You can't do the same clinical trials you did in the beginning. So you have to think about novel trial designs, you have to think of alternate approaches, and you have to think about what your endpoints are going to be, etc. And the human challenge studies could play a role here. Of course, the human challenge studies were also quite, there was a group who was for them. In fact, we had a lot of young people from the UK and from other countries in Europe who used to write to us at WHO saying we are ready to become volunteers for a human challenge study. Why aren't you doing these studies, and what is holding you back? So of course we put out a very balanced paper on the ethical framework around which such studies could be done, because at that time there was no treatment. Even about steroids we came to know later, there were no antivirals. So if you infect somebody and they get ill, then it's a real serious ethical issue, even though they may have volunteered, of course, for the study. But the advantage is you can finish your studies very quickly and you'll be able to find out whether a vaccine is really effective or not. And so there is a value, and I think India is in the process of setting up a few centers for human challenge studies, because this has been done in the past for malaria, for typhoid, for cholera. So studies have been done mostly in Europe, but it is complicated in the sense that you have to have a very strong ethical oversight. The other thing where we were weak was in antivirals, and the world just did not invest in antiviral R&D. And if you look at generally at viral infections that affect us, we don't have good drugs. So what was useful was the fact that things like corticosteroids and a few other immunomodulators, they were shown to at least reduce mortality in the sick patients. But a lot of research happened, and I think now at least there is the hope that in the future there'll be more investment in antivirals. Then on safety, and again, this was a issue that came up a lot with the general public, and we used to keep on getting asked the question, how do you know this vaccine is safe? It's been developed so quickly, and you have given emergency use authorization so quickly. Can you guarantee that this vaccine is safe? Okay, so when you're faced with a situation where a lot of people are dying, then you have to balance the benefits versus the risks. Luckily for us, the risks were very, very low, very extremely rare side effects. But that may not have been the case. You could have been in a situation where once you start vaccinating people, you start seeing side effects. And so you have to have a good system of monitoring, of surveillance, of pharmacovigilance, as it is called. And these systems cannot be built up during a pandemic. So all the things I'm talking about cannot be built up during a pandemic. So these are systems that you need to develop, and it's good for, even when you don't have a pandemic, it's good to have these systems. But obviously, if you have an outbreak, then it comes it becomes very useful. Again, the assays and animal models. Again, what we found is different labs doing different assays with using different standards. So one of the things that people in WHO were trying to do was standardize assays. And because if every study starts reporting it using different units, then how do you compare? And this is what happened in the beginning. Different companies were testing their own vaccines using their own assays. Of course, at that time, you can't blame them. So this is why we again said it's important to understand immunology, viral pathogenesis, and we need to understand the correlates of protection. which is quite difficult. It's not always easy to find a correlate of protection, but if you find one, then it is very useful to do studies. For example, in HIV, we know that the viral load is a good correlate of protection, whereas in TB, we have no such correlate. And so that becomes a bit challenging for developing new drugs and vaccines. So that's another area of research. And then, of course, the manufacturing issue is important, as I mentioned. What we found was that as far as the mRNA vaccines were concerned, we requested Pfizer and Moderna, and I had any number of calls with the senior leadership of both those companies. Will you please share your technology? Let's transfer your technology to other companies which are willing to make mRNA vaccines, and we can make a lot more. This was in 2021 when there was a shortage because every company could only manufacture so much and the whole world wanted these vaccines. But they refused. And so we then decided that we would set up our own technology transfer program. And so we set up what's called the mRNA Tech Transfer Program, where essentially a group of scientists and companies in low and middle income countries come together and work on mRNA based on data that's available in the public domain. This is different. This is about research. But I don't have a slide on the mRNA network, but it's, again, as I said, 16 countries, including India. And essentially, we had a hub in South Africa with all of these other centers as spokes. The idea is that this platform, mRNA, is going to be very useful, not just for other vaccines, but also for other therapeutics like cancer drugs, monoclonal antibodies. So a huge amount of potential there for R&D, for developing products. And why should it be in the hands of one or two big, companies in the West? And so we wanted to basically democratize this knowledge. And so this network today is doing quite well. Different groups are working on different diseases, but they share information, they share knowledge. And the main advantage is that if any group develops a vaccine or a product, they will license it to all the other countries as well at a reasonable rate so that everybody has access to the product. So this is the difference we are trying to make in the R&D system globally, where today it's driven by private investment, by multinationals who then basically put profits as their priority. Whereas what we're saying is that for life-saving, mainly all the health products like vaccines and drugs, the motivation should be to save lives, not to make profits. Of course, you have to cover your costs, but the kind of profits that these companies made was quite unreasonable, if you ask me. So this is a new type of experiment, and a lot of people try to discourage us and say this is not going to work, complete failure, etc. But anyway, 3 years down the line, it is still quite vibrant, and we had a lot of political support because many African leaders, especially, wanted that something like this should happen so that they can also build their capacity. Now, this slide basically shows that it was this kind of a global network that worked during the pandemic. I told you we had all these expert groups, over 3,000 researchers from 134 countries, and you can see that over 1,000 institutions were involved. And the solidarity trial that we ran in the beginning, we had again over 1,000 co-investigators from about 50 countries, including India, that participated in the solidarity trial that told us quite early on that hydroxychloroquine was not effective. So clinical trials are useful. Of course, you hope the drug is going to be effective, the drug that you're testing. But it's equally important to know if it's not effective, because you don't want to be giving people drugs which are not effective because you're exposing them unnecessarily to side effects. And of course, there's the cost. So a lot of repurposed drugs were put into trials. Most of them were found not to be very good or of any use. And the main drug, of course, was corticosteroids. And later on, we had drugs like Paxlovid, which did have some benefit. So basically, this R&D blueprint, the way it's set up now, this was the old model where they had a list of 10 diseases which were called the priority pathogens. And the last one was originally called as disease X, and that disease X turned out to be COVID. Of course, in the future, we will have another disease X. So we have to be prepared for the next one. And essentially, what we need to look at is, again, a research roadmap. If you had a new pathogen, what are the things that you would want to do? Diagnostics, vaccines, drugs, clinical care, etc. How will you do it? Do you have a protocol ready? For example, for Nipah, we have outbreaks of Nipah from time to time. We've had 3 outbreaks in the last 5 years in Kerala. Luckily, well contained, but we don't have an effective therapeutic or a vaccine. There is a monoclonal antibody. The next time somebody gets Nipah infection, we should have that monoclonal ready to be tested, even if it's 1 case or 5 cases or 10 cases, because that's the way you can collect information, especially for rare diseases. So you need the protocol, you need the approvals, you need the ethics, you need everything. You need the antibodies sitting in a fridge somewhere which can be immediately sent to the hospital and the patient enrolled. We also need, I think, a network of hospitals, clinical research centers, which can participate in clinical trials on a regular basis, but also in an emergency like this, they can get activated very quickly. So the ICMR is investing now in developing these type of networks. What happened in the UK, again, because of their NHS and the system they have, where all patient data is collected, and it's available in a digital format. And so it was very easy for them to run a multicentric clinical trial centrally, very quickly, and collect patient data on outcomes. So the Solidarity trial was also done for the first time completely digitally, and it enrolled about 25,000 patients from around the world. So that was also quite successful. Research also has to have fair and equitable access in mind. The goal should be to address questions important for public health, particularly when you're talking about these types of diseases, and try to inform public health actions. And when we have contracts between government and the private sector, for example, the government, of course, when they pay, they use taxpayer funds, and so there should be clauses in the agreement or the contract which will define what access should be, and issues related to intellectual property and tech transfer should not be afterthoughts. They have to go into the contract right from the beginning. And I told you the different models that currently exist. Now, we also try to do a lot of work with the World Trade Organization to see whether some of their trade rules could also be adapted or modified for pandemic situation, because the supply chain issue was something that was quite serious at one point. So some of the lessons I think that one learned is that preparedness is important at the national and the global level, and for a country like India at the subnational and sub-subnational levels, obviously. Now, at the global level, some of you may be aware that there is a pandemic treaty that's being negotiated at the World Health Assembly by member countries, member states. And the idea is to not repeat the mistakes of the past, but to have a response during a pandemic that will be more rooted in equity. So the word equity is at the heart of that pandemic accord. They have only a few weeks left to complete the negotiations, and as far as I can see, it's the same. The high-income countries on one hand and the low-income countries on the other hand. The high-income countries do not want to compromise or give away any of the control that they have over the market in terms of intellectual property that their companies hold. And so for them, that's very important. And the low-income countries are saying, no, will not work. We have to have a different system. So let's see what comes out at the end. So that's at the global level. The international health regulations are also being modified. But at the national level, the Niti Aayog, Dr. Vinod Paul, has actually set up a group that I'm part of, a small committee with Dr. Renu Swaroop and myself. We're looking at what do we do nationally, what do we need to do in terms of having a blueprint, both for epidemic and endemic pathogens, clinical trial networks. I mentioned ICMR is doing that. How do we test, the rapid response trials? We have to test the system. You can't wait for an emergency. Invest in platforms. So one of the ideas now is to create prototype vaccines. So let's say you have the coronavirus family. The goal, of course, would be to have a universal coronavirus vaccine. Not for every coronavirus you have to develop a new vaccine, but if you had a universal vaccine, whatever the coronavirus, you would get the same jab, it would be effective. The same thing would be very good for flu as well. So there's a lot of research going on. How do you create a universal vaccine for a whole group of viruses? It's difficult, it's not that easy. But similarly, there are about 30 other groups of viruses that can actually cause serious disease in human beings. The monkeypox is an example. It did not really take off in India, so I think we were very lucky. But in Africa, it's actually creating havoc just now, and people stopped talking about it because, again, the high-income countries, as long as they were affected, their gay population was quite badly affected in Europe and the US, and they wanted vaccine, they wanted everything. But children in DRC are dying of monkeypox, but no one's talking about that. So monkeypox vaccine, again, was, there's some candidates sitting in somebody's fridge, but they had never been fully developed and licensed. Similarly, we, need vaccines for other diseases. So prototype, if you have a prototype pathogen for each of those viral families, let's say 25 viral families, then that vaccine could be very easily used to develop a more specific vaccine. When you got that outbreak, and then it could be tested. So globally, that's the goal. So I'm sure that in India also, given that we have both excellent academic facilities as well as the private sector, the manufacturers, this should be possible that we invest in a number of different platforms, because the next time around we don't know whether the mRNA will be successful, or you'll have to use a conventional platform like an inactivated vaccine or a viral vector, or maybe even the new DNA platform that ultimately was not used, but a vaccine was developed. Regulatory pathways are important. I think I talked a little bit about how do you license a product in an emergency. And again, that needs capacity, it needs thoughtfulness, it needs experts, it needs also transparency, because that's the only way to have trust. If people don't trust the regulator, then there's going to be vaccine hesitancy and all kinds of problems. Then the social science aspects are very important. We should never forget that social and behavioral science plays a very big role in public health, not just for vaccine acceptance, but across public health interventions. If you don't communicate well, you don't convince the community, you're not going to get any kind of cooperation. And then, of course, we need labs that are accredited, that can perform all these different kinds of assays that you need. One lab is not enough, obviously, for a country like India. So now they're setting up so many BSL-3 labs. There's a One Health Institute coming up in Nagpur. And you need sustained funding for science, because you don't know when the next disaster is going to come. And so the funding must continue, and it has to be diversely spread across many different areas. Now this, basically, you can just look at the center part, which essentially talks about when you have a problem like a pandemic, then the different pillars you need really to think about is, the first one is surveillance. And you need surveillance built into routine surveillance, because in India we do have routine surveillance for respiratory illnesses. We need to expand our genomic sequencing capacity, and also keep a close eye on hospital admissions, deaths, and at the district level, we should have the capacity to be able to identify anything unusual that is happening. And so the idea is to have like a district epidemiologist who's well trained and who can pick up these unusual things happening. You need the community protection is basically vaccinate the most vulnerable, understand what people are saying and thinking, and of course involve community members, leaders, etc. Then clinical care, we need to have good facilities. Oxygen, as you remember, was a problem. So essential health products must be available at all levels of the health system because they can save lives. And then you need the access to the countermeasures like therapeutics, vaccines, whatever it is, what we've talked about just now. And going forward, of course, COVID has been integrated into the broader health system. It's no longer um, taking the sort of majority of the space there. And then you need the coordination part of it. So maybe very quickly on genomics, I think we've already talked about genomes and mutations and things like that, so I could skip this part. But I'm happy we touched on that, of course, because we went to the lab of genetics today, and we know that Dr. Ray-Chaudhuri was, one of the pioneers, and it was a passion of his, and he wanted India to advance in this field. Now, there was one other thing that was going on, and that was the infodemic. The infodemic was basically the mis and disinformation that was also spreading as fast as the virus. And so a whole discipline now called infodemiology actually has been created. It's a multidisciplinary discipline. And so, yes, so you can see that there's even a research agenda for how do you manage infodemics. And actually it is a serious problem because it's not just about COVID or about vaccination, but there's a lot of anti-science out there, particularly in the social media. And we experienced the first pandemic, of course, in the social media age. So I think the difference this time was that vaccine hesitancy or the anti-science messages were spreading much more faster because of social media than they could in the past. But it's important to understand what happens. How does this get triggered? How does it catch the attention of people? Why does it spread? And why do people believe these messages which they get? And how do they behave online? And how does that affect their offline behavior? So that is something that I think we're going to need social scientists and others to really think about and address. Luckily for us, as I said, we didn't have a big problem with vaccine hesitancy in India. It was small pockets here and there, but that was very well managed. But ultimately, I think that healthcare systems are going to be and should be transformed by the pandemic, because if we don't learn the lessons and act on it, then it's pointless having been through all that suffering. And so, we've talked about some of the lessons that we've learned. We know that outbreaks are a part of life. They're going to continue to happen. They may be small outbreaks, they may be large, but we need a system to manage, and we need very good communication, especially when it's an emergency situation. We need accurate communication and transparent and telling people often. Very often you don't know, so that it's important to also tell people we don't know. We are working on it, but there's no point trying to guess something which is untrue. Communities need to be engaged, and as I said, what's known as the soft sciences are extremely important, the social sciences. And so I would conclude by saying that we, I believe, need to invest in preventive healthcare, not just in building more health facilities, but really in preventive healthcare, because that's the way that we can actually improve our health and well-being, which means health promotion. It means attention to the upstream risk factors. And what are the upstream risk factors? They are things like nutrition, physical activity, having access to open spaces, pollution in the air, pollution in the water, etc., our diet, mental health. This is what keeps you healthy. And if you're not healthy, then of course you're more susceptible to a virus or any other disease. Our frontline workers are excellent. The ASHAs actually received Public Health Award from WHO in 2022. We have 1 million Ashas in our country. They do an amazing job. I've met, wherever I go, I meet them. But they obviously need further strengthening, training, better pay, and empowerment. Definitely need to enhance our disease surveillance, particularly what we call now One Health surveillance, animals, environment, humans. You would have seen that wastewater surveillance, something that came up during the pandemic. It has been used in the past for polio. Wastewater surveillance can be used now to track many infectious diseases. So some cities have started doing that. Health literacy is important. People believe all sorts of things. People rather believe their neighbor than believe the doctor or the nurse. So we need to really get people to think scientifically, rationally, and as I said, work on their own health promotion. Universal health coverage we have through the Ayushman Bharat program. We are expanding the universal health coverage in the country. That needs to continue till every person in the country has access to quality health services without having to pay out of pocket. Our out of pocket expenditure is still very high. It's come down from 60% to 48%, but 48% is too high compared to, say, a country like Thailand, our neighbor, where the out of pocket expenditure is less than 10%. So we have a ways to go. Equity, human rights, gender, and social justice should underpin all our programs because we have to reach the most vulnerable person. Otherwise, it's not a good public health program. We did a lot of work on telemedicine and digital health during the pandemic. We were able to do a lot of outreach. So that's a great advantage for us. We have the systems, we have the infrastructure in place, and so we can use digital health services quite effectively for a number of indications. And I think more research is needed again on where the digital health applications can have the most impact. And this includes artificial intelligence, for example, in early diagnosis, where you don't have a radiologist, you don't have a pathologist. AI has been shown to be quite good, especially when it comes to image reading. And then finally, I would say that why did this pandemic arise? It's because of our destruction of the natural habitat of animals and birds, so that they're necessarily coming into more contact with human beings and also with domestic animals. When you have a mixing of domestic and wild animals with humans, somewhere there's always a chance of these viruses jumping. In the past, this might be happening, of course. So it's nothing new. Zoonotic infections, we know, and they would happen somewhere and it would affect a few people and it would die out. But in today's era of globalization, we know that an infectious disease starting in one remote village, within 36 hours, it will be spread around the world just because of the way we are connected. And so there's nowhere in the world today where you will not, it would be safe to have a new outbreak. So knowing that, obviously we need to, and also with the big issue of climate change, it's all connected. The loss of biodiversity, climate change, the human-animal interactions, the threat of future pandemics, and of course the other impacts of climate change, which we are seeing, are all interconnected, and therefore our response also has to be more holistic. That is easier said than done, but I think that's going to be ultimately needed if we are going to keep ourselves safe from future pandemics, but also from all the other threats that we face because of this triple threat: the biodiversity loss, climate change, and pollution. So with that, I would like to thank you again very much. Appreciate all of you coming to listen, and I've enjoyed my stay here in BHU today. Thank you very much, Professor Rajiv Raman, and all of your colleagues for making me feel so hospitable.
I have one or two questions because we don't have much time.
Thank you very much, Doctor, for your wonderful talk and the details that you provided. Since we're in India, there's a deep history of Indian knowledge systems and Indian medical systems. And I am wondering if you could add something about the lessons learned from Indian medical systems and what was done during the pandemic. I know that I personally worked with some African traditional medical systems and the vaccines and approaches that they used. We have antivirals in Ayurveda that are quite effective in neem and goduchi and turmeric. Can you add to what they contributed and why they were not able to contribute? I'll say Ayush in general, why they weren't able to contribute on that global data level. Thank you very much.
The traditional systems of medicine do have a role to play, both in prevention and in treatment of different diseases. But we need to create the evidence base, and the evidence base has to be created in a way that is understandable to people. So I think what happened was that there was a mad rush to try all kinds of things. I'm not talking only about Ayurveda here. There were a lot of drugs also. Was just somebody was promoting, or maybe in the beginning there was some theoretical explanation for why a certain drug might be effective. The correct response to that is put it into clinical trials, not just start distributing it to people. So I think that was a gap, and it's a lesson that we learned, and because every drug, has benefits, it also has side effects. So unnecessary use of medicines should be avoided. There are also medicines that might promote general immunity, like I think Ayurveda, especially if we are looking at specific outcomes, like will it reduce deaths? Will it reduce the post-COVID side effects? I think that is a very good area for research for Ayurveda. Post-COVID, long COVID syndrome. And I'm not sure if there are any trials.
Please come and present a small memento to Dr. Swaminathan. Thank you.
इसको ही बनाने में बहुत टाइम लग जा रहा है, तो क्या बात है? Well, good afternoon, ladies and gentlemen. Let me, at the very outset, thank the organizers, particularly Rajiv Raman, who invited me to be here. As usual, I always see pleasure coming back to BHU campus. You love it so much. And that is how I accepted to be there. The other reason for my accepting to chair this session was because when Professor Raman told that Dr. Soumya Swaminathan, is coming to deliver this lecture, I purposely thought that I should come and listen to her and see what all that she is going to do out of her great experience that she has gathered around in different capacities within and outside the country. So that was the reason I thought that I will be here. The other reason why I said it, because Professor M.S. Swaminathan, one of the very, very outstanding stalwart in science, particularly in agriculture, he passed away only a few months back. I mean, unparalleled personality. And Soumya is daughter of Dr. M.S. Swaminathan, who has been my mentor, our mentor, I would say. As a matter of fact, my first entry in the ICR system in 1972 was signed by Professor M.S. Swaminathan when he joined ICR as Director General. When he left ICR as Director General, then he signed the second one when I got into the headquarters as Assistant Director General. So I was actually so closely associated to him during my IL capacity that I worked right from agronomist till the Director General of ICR. I think we have, and therefore we are really privileged to have here. And I'm not going to make any remark that what she said, but you will very largely, all of you will agree that it was a very comprehensive, exhaustive lecture, reminding us of the great disaster that we faced 2-3 years back, always praying that it should never come back. But when you look to her presentation, you can very confidently say that we have our preparedness, particularly India, and we must thank her especially because being at the UN in the WHO at the headquarters, she only not coordinated globally, but had been very useful in sending out messages to the country, India, that this is what is to be done, this is what is not to be done, and that kind of felt that we got from her. And as she very one way said that about 4 year part in pandemic, she could have done much better other things, but even the work that she did for the country was a great thing that we do. I think that was the reason that I am really, they have selected a very good among the top speakers who came in the past. She is one of them. And we had a very good lecture that she gave to learn to us. Professor Ray-Chaudhuri is remembered. He joined this institution, I was told, from Calcutta University as head of the department. He remained head for 6-7 years, 11 years, I think, 60 to 71, and developed, the basic structures, the very basic framework for, genetics and animal cytogenetics research in the country. And that sets a pathway, a roadmap on which I think most of you are now walking or running. And I think that's a band of network that has been created, has been all done by Professor Ray-Chaudhuri. It's very appropriate that in his memory and because for his contribution, we remember him and organize this today, the 24th S.P. Ray-Chaudhuri Memorial Lecture with a very eminent speaker that we have. Now, Dr. Chaudhuri, for that purpose, if you look to that kind of, brief that you read, and for that even everybody, even the lecture that you had, all science that you are doing is science for society. We say science for human face. That means look a person and science is for him. If science is able to serve that person, this is science. Otherwise, he keeps circumventing around and you don't know where we are going. So that always you keep in mind. I think emerges very clearly that science with human face, science for society, becomes the major crux and core of the heart that we are doing that. And very important thing emerged from the lecture that it has to be a holistic approach. Science today is very different. If you talk particularly, let's say, because I'm in agriculture, as I said, if you talk agriculture science today, science of yesterday was very different than what we have today. And science of tomorrow is going to be, you can't just dream, very, very different. From plow to AI, robots, drones, sensors, AI, everything we are talking, and it is all implemented in agriculture science today. What I'm trying to say when she referred to holistic approach, it is not an individual can be at the drum. Now, anything, whether it is even in agriculture today, your science that the project with the medical science, the project with information technology, the project with whole IT band, and even physics and chemistry are operating in science and really attacking to a problem where you are really able to give a solution which we call is sustainable and can be really applicable. And that I think particularly for the young scientists again in front of me, you keep in mind that you are going to do something individually you may not be able to really do something which you think is very high. Of course, your own research is very important, but then when you're really going to serve and make us to what we should do, you have to have a very comprehensive and very, you know, a very holistic approach. And that is where she referred, you have that holistic approach has created a platform for mRNA platform, rDNA platform, which is now being used and maybe modified, because I've heard that with time changes, because we are all aware of it that pandemic COVID created disaster, but that does not mean this may come in a different form. But our preparedness in science that is being taken, the global approach that is being taken for this particular disease or pandemic, she has very clearly made us understand. And what has been the step that went forward to really tackle this problem? It speaks of one very, holistic approach where all kinds of people, including society, they have worked to take care of this pandemic that came up. And that's the reason that we could have lost maybe much more than what we are dreaming today in the pace that you have. And that is being challenged today. Today's challenges, of course, you have seen the biodiversity loss, the animal or plant biodiversity, natural resources loss. Today we are challenged with utilizing or increasing the resource use efficiency, which is one of the greatest challenge that you have, whether it is soil, whether it is water, human resource, biodiversity that you talk. So therefore, today's agriculture, today's science is very different, as I said, because yesterday we produced at the cost of what we lost today. We say that we have produced, we are now second or first in the whole world as far as production is concerned. But we also say that we have lost water, we have lost soil, we have lost biodiversity, and therefore we are not able to really control that. Now the challenge is how you take both it up. And therefore science has to be highly integrated, highly holistic approach, so that you are able to move forward, increase science capacity and delivery, at the same time save the resources you are using, because you have to leave something for the posterity and don't finish everything that you have. And that is where the total SDGs, 17 SDGs, Sustainable Development Goals, address, whether you talk in terms of climate change, you talk in terms of biodiversity conservation, you talk in terms of natural resource conservation, everything focuses on that ultimately you are working for prosperity and peace for human being and save the human life or the planet, Earth itself. And that is the mission that goes on that. And I think that is where we see that we are able to assess. The whole effort that the speaker made today was to think about, what we say, and the think globally, but act locally. And while acting, get all players, get all, people who are concerned to bring together to answer to the problem, then only reach to the final solution. At the end, she gave a very complicated, a diagram where you find it's a market, and that is what we call the infodynamics, info epidemiology. That means you have to think, and it's very good to give that, but you have to think, keeping all those players together, they can make wonder both way. It could either become a mess, because you may not be able to understand what you are going to do with lot of, when you get into all these, to collect so much data, get into this. And as she was also saying, when we started using models, a lot of modelers emerged. And I tell you, 80% of the models must have failed, because you get very quickly design some data, get some data, and then develop equation and get a model, and then very quickly that is refused. So therefore, when you're actually going to talk about info epidemiology, I think we have to really see as to what you are collecting, what you are doing. And if you are able to really do that, I think that is where the use of AI is now being talked about. To collect whatever you say, it will be able to predict you something which you can do. And therefore, I think we should be prepared to use that whole set of gamut in the science that you're talking and bringing in that. So without taking much of your time, I will only say that it was a very productive, very exhaustive, and very good lecture. And of course, reminds of the threat. You get thrilled, when you listen to COVID, but don't get thrilled because we prepared it. Now you might get something different, but the attempt that has been made, I mean, there's absolutely no doubt, even for India, a country like India, it was a very big challenge, but what handled very, very methodically, and we have been able to save millions of lives. And in that whole process, the role of Soumya Swaminathan cannot be ignored because he has been at the headquarters where the health issues, particularly issues, was taken, and her contribution was of great importance. You must have seen messages coming from her, you know, uh, guidelines coming from her, for countries, including India, to what is to be done, what not to be done. So I think that was a great contribution. So we thank you, Dr. Soumya, for a very wonderful lecture. And thank you, Dr. Rajivan, for having us here, and to all of you, my teachers. As I said, good to see good young and old faces when you come back in the campus. And wish you all the best, and take lessons from what you have heard and try to mold yourself on how to move forward in tackling a problem. Such problem is one, but ultimately are working for somebody who is looking for your science to be used by him. I think that's the focal point you addressed. That. Thank you very much, and all the best. Thank you.
Respected dignitaries, senior professors, teachers, students, guests, a very good evening to all of you. I want to start today by thanking our speaker, Dr. Soumya Swaminathan, for delivering an amazing talk on the lessons, what we have learned from the pandemic, and what will be the impact of this in coming years. It was a very inspirational and informative talk, and we are very grateful to you, ma'am, for your insights. I would also like to express our heartfelt thanks to our chief guest, Professor Punjab Singh, for accepting our invitation and taking his valuable time to be with us despite his busy schedule. So thank you, sir. This year, we have launched a drive, a life membership drive for Professor S.V. Ray-Chaudhuri Foundation, and we have received generous contribution from many donors in India as well as abroad. So I want to take the opportunity to thank everyone who has contributed to this foundation. I want to thank our director, sir, and dean, sir, for providing access to this hall. Additionally, I also want to take an opportunity to thank our head of the Department of Zoology, Professor Acharya, for making the department hall also available at our disposal. We are also thankful to the director and registrar of IIT BHU for the hospitality of their guest house. In organization of this lecture, many students and non-teaching staff were involved, and we appreciate your efforts, so thank you to you. Finally, I want to thank each and every one of you in this audience for attending today's lecture and taking time to be part of this event. So at the end, thank you, and I request all of you to please join us for a cup of tea, which is served outside.